First, let me thank the AIOC organizers and Dr. Bishwas for giving me this opportunity. I'll be talking about OCT, role of OCT in uveitis. Why it is important? As we all know, ancillary investigations are the backbone of uveitis workup. They help in making the diagnosis and ruling out certain differential diagnosis and also monitoring inflammation during follow-up. OCT is an optical biopsy of posterior segment structures with a high resolution, reproducibility and precision that correlates well with histology sessions. It helps in the localization of pathology by defining the extent, depth and thickness of the inflammatory lesion. So we will start from anterior and intermediate uveitis. Why to do an posterior segment OCT in an anterior and intermediate uveitis? To identify a CME. OCT helps in quantifying the macular edema, which has 89% sensitivity for the diagnosis of CME while comparing to FFA. Three distinct patterns of macular edema detected in uveitis. First is diffuse macular edema, then cystoid macular edema, then concomitant serous retinal detachment. The first picture shows diffuse macular edema with a serous retinal detachment seen in Behçet uveitis, and second picture shows a cystoid macular edema with a small serous retinal detachment in an intermediate uveitis, and third picture shows a persistent serous retinal detachment as well as few cystoid spaces along with ERM. This shows a typical cystoid macular edema which resolves well with the treatment. Another case of cystoid macular edema with the SFD started responding to a treatment. Quantitative analysis of macular thickness helps in monitoring the response to treatment, and these are the predictors of poor visual outcome in an OCT, like atrophy and disorganization of inner retinal layers and disruption of outer retinal layers. The presence of vitreomacular interface anomalies like ERM, VMA, VMT and macular hole indicate the cause of treatment failure. The first picture shows an ERM and second picture beautifully shows a vitreomacular traction. Now coming to posterior uveitis, occasionally posterior vitreous cells can be seen in an OCT as hyperreflective vitreous particles with or without CME. Now coming to a retinitis lesion, OCT shows hyperreflective thickening of the retinal layers with shadowing, and in this picture you can see posterior vitreous cells also shows an active retinitis lesion, and the same lesion responding with treatment showing thinning of the lesion and disappearance of the vitreous cells. Another Behçet uveitis with a retinitis patch shows a hyperreflective focal retinal thickening with shadowing beneath the lesion, and while resolution of the lesion shows a pseudofovea-like picture. Yet another case of TB choroiditis, can very well see RP is elevated due to choroidal thickening, and there is a fluid detachment also. While treating with ATT, the choroidal thickness resolved and fluid detachment also. Now it's a case of retinochoroiditis, which shows a full thickness hyperreflectivity and disruption of the retinal layers in the necrotic area with shadowing along with choroidal thickening beneath the lesion. The second picture, a typical choroidal granuloma characterized by hyporeflective thickening of the choroid with fluid detachment. It's a case of serpiginous choroiditis with an active and a scarred area. The active lesion shows again thickening of the focal choroid and hyperreflective deposits in the outer retina. shows the yellow arrow shows the active part, and hypoautofluorescence scarred part characterized by loss of outer retinal layers and RPE, and the choroidal transmission is increased, so hyperreflective thinned choroid also seen underneath. This is a case of multifocal choroiditis. Again, active phase OCT shows RPE elevation by a homogeneous material and choroidal hyperreflectivity, and the quiescent stage OCT shows resolution of sub-RPE material. OCT also helps in identifying inflammatory CNVM, and it also determines the lesion activity to assess the response to treatment. Okay. Now OCT in white dot syndromes, spectral domain OCT shows photoreceptor layers and RPE disruption in OCT. And in exudative RD conditions like VKH and sympathetic ophthalmia, OCT is very useful in monitoring the serous retinal detachments. And the typical finding in VKH is SFD with subretinal septae. And EDI OCT also helps in monitoring the disease activity. So the take-home message is OCT is a very useful diagnostic modality for monitoring diagnosis and monitoring the inflammatory disease of the posterior segment. But don't forget about the history and clinical appearance. Thank you.
Thank you, Dr. Reesha, for